question. But what I wanted to pick up on is that we were talking about alpha 2s. And one of the big take home messages when you're monitoring anesthesia, any patient under anesthesia, the heart rate eventually is going to be lower than when they were awake. So anesthesia usually will slow the heart rate. We worry about when bradycardia becomes too much. I've told you that my comfort level is if they had a heart rate of 140 on their TPR, and then in anesthesia you drop to below, like, or at or below 50% of their original heart rate, then that's a pretty profound bradycardia. But the alpha 2s will drop it down into the 50s, 40s, 30s. But if a patient had an alpha 2, I expect that. I expect it to be that low. So I don't typically panic when I get those low heart rates if I'm using an alpha 2. And it happens in the early phase. And if I ask you, why does the heart rate drop so low with an alpha 2? It's because you get a massive vasoconstriction. And so all the blood from the periphery is vasoconstricted to the core. It causes an increase in blood pressure, very, very high, but the heart rate slows down as a reflex bradycardia. It's a normal reflex to hypertension. Now, what's going to happen in the late phase is that the blood pressure is going to come down as the drug wears off, usually after about 20-30 minutes, and then you can see the bradycardia maintain, or it can remain about the same. I'm going to tell you a little tip, and this is important. When you guys are in radiology rotation, and all these dogs and cats typically get dexmedetomidine, which is an alpha 2, their heart rates are going to be low. My comfort level is, there's going to be times where you guys aren't moving them for an x-ray. You're going to be developing the film. And so the patient is just laying there. Usually when they're unstimulated, the heart rate comes down. When you start moving them, the heart rate goes up. If I have a patient where the heart rate's like 30, 35, 40, and it doesn't move, if I'm moving them, I'm opening their mouth and all that, I'm a little more concerned. But most of my patients, if I stimulate them a little bit, if I open their mouth, if I tap their eye, if I fluffy, sometimes I'll see them come up a little bit and they'll go back to sleep. Then I don't feel as uncomfortable. The ones that I've been concerned, when I get concerned, is when I get that really, really low heart rate and they're not really responding to stimulation, their name, and movement. Then they're a little bit deeper, because I will tell you, on alpha 2s, they should be somewhat responsive to their name. They should be somewhat responsive to movement. Okay, they're not anesthetized with an alpha 2, they're just sedated. It's just a very profound sedative. So this is where, when I have my range of light sedation and deep sedation, my benzodiazepines like diazepam are very light. Acepromazine is somewhere in the middle. My alpha 2s are usually deeper. So if I'm grading them, like shades of light to dark, shades of light to deep, the alpha 2s are going to be more profound. And there's only one category of drug that really drops their heart rate that profoundly, and that's alpha 2s. No other drug that we use causes that bradycardia. That's why if it drops that low and you've not given one of these drugs, then that would be a cause for concern. So that's kind of that's part of that analysis. Here's a problem. What drug did I give my patient? Does my drug usually cause this problem? And that's either a yes or a no. They are respiratory depressed because they're sedated. Good muscle relaxation. It does potentiate other drugs. Now, vomiting is important. A lot of times, alpha 2s in general can cause vomiting in about 50% of dogs, but I want you to know 90% of cats will vomit after they've been given an alpha 2. Now, when we give cats kitty magic, I explain kitty magic is dextrometor, maybe buprenorphine and ketamine. Sometimes the ketamine and the buprenorphine kick in and sedate them before they vomit. But I'm going to tell you, a lot of times in practice, we give a cat kitty magic, or we give them an alpha 2 pre-med, and we go stick them in the back, in the kennel in the back. Well, I've gone back there and found cats laying in their vomit. It's like they vomit and then they fall asleep. So when I use these drugs, you want to keep a close eye on them, because we wouldn't want them to aspirate. We wouldn't want them to vomit, fall asleep, and then potentially inhale that. So I will tell you right here, it is the emetic of choice in cats. If you have a cat that ate a Tylenol tablet by accident, if the cat ate a lily, I think about what are toxicities in cats that, most cats don't eat chocolate. Most cats don't eat onions. If you think about, and most cats don't eat grapes, but things cats like to get into are, well, plants. Cats love plants. So plant toxicities, I mean, if anybody owns a cat, and even my own husband at Easter came home with this arrangement from Costco, and there's a bunch of lilies in it. And I'm like, well, I'm sorry I have to pull these lilies out, or I'm going to go put this arrangement on the front porch. And I'm like, the lilies are toxic, and they're in a lot of Easter plants. So poinsettias at Christmas. I've never owned a poinsettia because I have cats. So if a cat eats a poinsettia, a lily, if they get a tablet, we will usually give the cat an alpha 2 versus apomorphine. Now, apomorphine is what we use in dogs. It's a much more predictable. I would never really give xylazine or another alpha 2 to a dog to make them vomit, but a cat, it works great. They will become a little hypothermic because they're vasoconstricted, so they can get a little colder, and they can get a little hyperglycemic with this drug. So if you have a diabetic patient, in diabetics, we worry about hyperglycemia anyway. I probably wouldn't pre-med a diabetic patient with an alpha 2 because I don't want to make the hyperglycemia worse. So you see, this is kind of my, like, what does my drug do? What's wrong with my patient kind of thing. So CNS, you can get changes in behavior, but the sedation with this drug is pretty profound. I talked about aggression being sometimes worse with acepromazine. I don't see it with these drugs. But any dog that is sedated, and this is really pertinent for you guys in radiology, because sometimes the dog's laying there and someone's going to drop those metal calipers. There's calipers where you measure the patient. I've seen metal hit the floor and these dogs just jump up. And even there was a surgery rotation where all the students were turned around from a dog, and he got up and he fell off the dental table. I walked in there once and I saw them standing with the sedated dog prior to induction, and not one person was looking at the patient. And they definitely heard about it from me, because I said, why was everybody in here and nobody was looking at that dog? It could have taken a millisecond for that dog to fall off the table. I always have a hand on a sedated patient, always, so that if they move, I'm ready to react. So bradycardia, there is going to be some hypotension, but it starts out hyper, and then it's going to be respiratory depression. Some of the side effects or adverse effects, it can be increased urination, which, that is a reported side effect. You just have to make sure they don't urinate on themselves. There is some reports of cattle particularly getting bloated, maybe horses, an increase in salivation. So these are some of the weirder side effects of the drugs. Not used in pregnant cows because it can cause premature birth. So if we know we have to operate on a cow, then we're probably not going to use that. And can get sweating in horses. So again, you know, because remember, horses are the only species that profusely sweats. Sometimes it causes that. Why, Michaela? It's just the effect of the drug on the receptors. Because it binds to the alpha 2 receptors, they have a role in birth. So it can potentially induce an early labor due to the receptors. Is that what you were asking about, Michaela? About the birth. One thing that's important to know about this drug, okay, it can be absorbed through your mucous membranes or a cut, or if you accidentally injected yourself, and you would have the same effects. If for some reason, now if you get it dripped on your intact skin, you'll probably be fine. You should wash your hands. But if you got injected, if it's squirted in your mouth, potentially, oh, yeah, I don't know why they weren't paying. Like one was talking to someone, one was like looking at her anesthesia record. I don't know. I just walked by in the kennel and I looked into surgery and I'm like, nobody has a hand on this patient and nobody's actually looking at the patient. And it was just like the week before that the dog fell off the table. Now their dog didn't fall off the table. He was pretty asleep. I've seen dogs look zonked to the world, jump off, you know, try to jump up. So it only takes a loud sound. Most sedatives cause an increase in sound sensitivity. So again, they look asleep, but they're more sensitive to loud sounds. So you just have to be really careful when I just try to be really quiet. Don't talk loud. Be really cautious about dropping things. But as long as someone has a hold of the patient, you'll probably be fine. But actually, it can cause the same side effect in people. So if for some reason you were to inject it, you could become sedated, you could become bradycardic, you could become pale. Now, one thing I want to mention, do you see on slide 35, it says using large animal concentrations. Xylazine is an alpha 2 and it comes, well, I think it's coming up on the slide. I'm going to go ahead a few slides, but I'm going to come back to it. Xylazine is known as Rompin, and xylazine's been around forever. It's dirt cheap. It's been around a really long time, but there are two different concentrations. There's a 2% and a 10% solution. If you're going to get it for small animal, most of the time we use xylazine in large animal. There's not a lot of small animal practices that use xylazine in dogs and cats. Most people use dexdomitor. But if your practice carries both, one is 20 mg per mil, one is 100 milligrams per mil. The large animal is a much higher concentration. If your practice carries both, I would store them in different spots. These are not controlled, so they can be put on the shelf. But if somebody grabbed the large animal to sedate a dog or a cat, they could kill it. And if you get injected with the large animal, it's a higher concentration, you're going to see more side effects. So again, very important to know two different concentrations, and it can be absorbed through. There's not a lot of drugs that affect us if you would, like inject yourself accidentally. But the other thing about xylazine, and I'm going to mention, is it's more large animal, but it's less receptor specific. So when it binds to receptors, but it is not as specific to the receptor. And it is reversible, and it is reversed with yohimbine. This is the drug where I said, Yohim, be awake now. And yohimbine is specific for xylazine. So yohimbine is going to compete, and you're going to get reversal. Now, this category of drug I use with caution because it has profound side effects. I don't usually like it for geriatrics, diabetics, pediatrics, or very ill patients. So this is kind of a good drug for your average, everyday, healthy patient. Now, age is not a disease. Age is not a disease. Hang on one second. Okay, sorry, we're having mulch delivered and I thought they were here. The guy's driving down the street, so but my son's going to take care of it. So, okay. So these group of drugs, like I said, you can use this in a 10, 12-year-old dog, um, but if they're very, very healthy. And I would definitely, if you have to use it in a category like one of these patients, I would definitely use my very low end of the dose. Now, the controversy I've talked about is normally when a heart rate drops really low, people are conditioned to give atropine. It is controversial, and I feel like the veterinary world is split on this. I've had doctors, I know Dr. Ritz doesn't like the heart rate so low. I think Dr. Paul is a little bit more comfortable. My oncology boss didn't like the bradycardia. But when I worked with a criticalist and my anesthesiologist, and if you look at research papers, you shouldn't need to give atropine if if you're in a danger bradycardia, if you're in like it's super, super low, like I had that patient, my one patient went down to 23 for heart rate, and he was not responding to any stimulation, talking to him. I could have intubated him, which you're not supposed to be able to do. Instead of us giving atropine, we reverse the drug. So if you're in kind of like a trouble zone, the preferred treatment is to reverse the agent rather than to just give atropine, because atropine is only treating the bradycardia. If you're worried that the patient's too sedated, you got to get the drug out of the system. So I will tell you, people, that the best way to give anticholinergics is to give the atropine IM, wait 10 to 20 minutes, then give the alpha 2, then wait again, then do the anesthesia. So there's, like I said, I'm just giving you my opinion, and I know it gets frustrating for students because when you're learning, you're like, I want it to be this way, black and white. But there's lots of opinions and there's lots of different ways to do things. So you will probably, I don't want you to just go into surgery and go, Lando told us not to use atropine. It's ultimately up to the doctor. And different people, and again, the only thing I want you to think about is if you think about physiology, atropine increases the heart rate. And what's happening is when you give this drug, you have vasoconstriction. The heart rate slows down. Okay. When you give atropine, you speed up the heart rate. You don't do anything for the vasoconstriction. So now it's, remember I told you, I want you to blow up a balloon and I give you one of those little cocktail straws and you're trying to blow through that little straw to blow up the balloon. But what if I'm like, hurry, 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 blow it up. And you're like, what you're doing is you're speeding up the heart rate and you've got vasoconstriction. So it does increase workload on the heart when you give atropine with an alpha 2. And it does increase, whenever the heart works hard, it needs more oxygen, myocardial oxygen consumption. So we have the potential to set up some arrhythmias. Now, I've seen this given to patients, and the patients do fine. It's patients that fall out of that maybe normal kind of range that I might worry about this effect. But I just want you to know there are going to be people that give it. I'm not saying it's wrong. I'm just saying I was, trained one way, doctor. But again, if my doctor tells me to do it, I would, they're my doctor. That's, the patient's under their care. I'm just helping. Okay. So I'm not trying to cause a controversy, but it's in the research, it's in the literature, and I just want you to be aware of what might happen. Yes, because when you speed up the heart, Miranda, you have to remember when you first give the drug, they're vasoconstricted. So that's why the heart rate slowed down. But now you're having the heart pump faster with atropine, which makes the heart work harder, but you still have a narrowed outflow because all the arteries are vasoconstricted. So potentially the heart's working harder. But again, it's each doctor's preference. I would encourage you to talk to your doctor. You'll probably use it a lot. I just talked about xylazine. That's the main Rompin, is the one we use mostly in large animal. And then dexdomitor, which is dexmedetomidine, is the primarily one we used in small animal, dogs and cats. Okay, Katie, you're fine. I've had computer problems this morning, so we're good. So it gives you sedation and analgesia. Xylazine does too, sedation and analgesia. That's another advantage. It is more potent and safer than xylazine. What's interesting is dexdomitor binds to the receptors more efficiently, so you don't need to use as much. If you were comparing dosage mg per kg, because it binds better, it's more receptor specific, then it binds better. Now, again, large animal, they're always kind of like with their, I'm going to use my xylazine. When I do large animal next term, I'll get into, there's a few more large animal specific alpha 2s, but this one is primarily used in small animal. Its reversal agent is atipamezole, which is antecedent, anti-sedate, antecedent. So it is specific for dexmedetomidine. Now, if you were in practice and you gave dexdomitor, you couldn't find your antecedent and you had yohimbine, you could potentially use it. You might not get the full reversal. So you can, if you absolutely had to, in an emergency, use one of the other reversal agents. They're just not they're really made for their specific agent because they bind to the same receptors and they reverse the same receptors, but there's more specificity with dexdomitor than there is with xylazine, if that makes sense. Low doses is we can use this as a pre-med. Kitty Magic is an induction agent. So this drug, when you do Kitty Magic, which is ketamine, dexmedetomidine, and say buprenorphine, when you guys give that, your goal is to get them intubated. So that's an induction. But if I gave just dexmedetomidine, butorphanol, that's what you guys will use for RADs. Usually for your radiographs, you'll give the dogs dexdomitor and butorphanol. That is just sedative. If you add ketamine to that, like Kitty Magic, that's an induction agent. There are lots of recipes, or a lot of people make what they call cocktails, anesthetic cocktails. They're like, I'm going to mix this, and give this much per pound. So when you get to your practice, you would have to just, I always tell students, like, for example, you go on externship. I'm like, day one, figure out what drugs they use in their practice. They probably aren't going to have every drug I've talked about in class. And then you write down the drugs that they have, and then you go through your drugs write-ups, and then you figure out the pros and cons and the side effects of those drugs. You can mix it with other drugs. You can give it with butorphanol, with ketamine. So it is mixable, and that's another good agent. Also, there's a note on here, can be painful given IM. I mean, I'm always ready for a dog to react when I give them something in the muscle. So some react more than others, but bradycardia is the main side effect. Okay. That's the big thing we see, respiratory depression. I've told you what to look for. Now, alpha-2 antagonists. Let me talk about reversal. Alpha-2 antagonists, we're talking about antecedent and we're talking about yohimbine. A lot of people give it because they want to take away the bad things. They want to reverse excessive sedation and they want to reverse bradycardia. But when you take away the bad stuff, you take away the good stuff. You take away the good sedation and you take away the analgesia. So when you reverse a patient, you need to be ready that those patients are going to wake up abruptly. They can wake up. If you give it IV, 1 minute they're asleep, the next minute they're up looking around, they're like, whoa, whoa, whoa. Now, let me give you an example. When you guys have your radiology patients, if you reverse the dexmedetomidine, they still have butorphanol on board. So they might be a little bit sedated, but the primary sedative in that cocktail is the dexdomitor. Butorphanol is analgesia with like a little bit of sedation. So they're going to be pretty awake. You might get a little hangover from the butorphanol. Now, if, for example, you overdosed or gave the wrong amount of a reversal agent, you can get some salivation, you can get some tachycardia, you can get excitement. I want to give you an example. We were, when I was at Purdue, we used to have orthopedic radiology day. All the ortho patients would go down to radiology to get their pre-op radiographs. And so I would take vet students, tech students, and I'd have my little sedation box. And sometimes I'd have 3 dogs being sedated in different rooms. The students would come get their drugs, okay? I have one dog they gave the sedative to, and they called me over and they're like, he's not going to sleep. He won't go to sleep. And I'm looking at him and I'm like, you gave it IV? Yes. I'm like, you hit the vein? You got blood? Yes. And I finally, and this was not long after I just started using these drugs. And so I called my anesthesiologist and I said, why is this dog's not going to sleep? He goes, did they give the reversal agent instead of the dexdomitor? And so I went to the student and they went and looked at the bottles, and one is blue and what is an orange bottle. The reversal agent is the orange bottle. And then they were like, I maybe grabbed the orange bottle. So they gave the reversal agent IV, never gave the dexdomitor. So the dog was panting, salivating, high heart rate, like pacing. So what we did was that had to wear off. And then we waited till the next day to do his x-rays. There's nothing, we didn't want to sedate him. He already had the reversal agent on board. So we don't think the sedative would have competed. So, and rather than take him from this excited stage to then like sedate him, we just decided to just not do the x-rays and wait. So if you accidentally, I like to keep the bottles separate. And a lot of times students will draw up the dexdomitor, and a lot of doctors want you to draw up correct. So the reversal agents aren't reversed most of the time. I've only seen this happen one time in a very long career. So I don't think it's very common, but in that dog, he chose to just let the side effects wear off. I mean, the patient wasn't snapping. He was just kind of like in this excited stage. And in about an hour or so, he calmed down. So it didn't last very long. What was I just going to say? When you guys draw up the reversal agent, I'm kind of superstitious. I like have my dexdomitor and I have my other drugs over here. And I usually wait till I wait till after I give the dexdomitor, then I drop the reversal agent so I don't accidentally grab, or I put the bottle in a different location. But some doctors want the reversal agent drawn up at the same time. Yeah, the reversal agent is orange. The bottle, the labels, one is blue, one is orange. So yeah, the drug itself is not orange. Sorry, the label. The drugs are clear, so they look exactly the same. In a syringe, you won't be able to tell, but if the bottles are different colors. Now, reversal of agents, this dose, agonist to antagonist, is 10-1. What I want you to know or put a note is every time I've reversed, if I draw 0.2 dexdomitor, I draw 0.2 antecedent. It's usually equal volumes. So ignore this thing. Just dexdomitor, Ray. Yohimbine is like a white label and it just says Yohimbine. So, but for dexdomitor, that's a bluish aqua label, and then the antecedent is an orange label. Yep. Yep. No, thanks for saying that, because that's a good question, because all reversal agents could have been like, we're all orange. Just that just pertains to dexdomitor. So you guys, what I want you to know is normally, if you look it up in Plum, there is a dosage for reversal, but every doctor I've worked for, we just draw up equal volumes. So whatever you drew up for dexdomitor, you drop the same volume for the reversal agent. Now, reversal is controversial. Oh, that rhymes. Most of the time, I want to highlight there, if you're going to reverse them, it's better to give it IM. I only use IV reversal if I'm in trouble. If I'm really worried about my patient, you know, that dog that was like 23 heart rate and he was out, we IV reversed him. And a lot of times doctors will have you give half of the reversal. Sometimes they're like, don't give the full dose, because think about it this way. If you've had a dog under for 45 minutes to an hour, that drug that you gave is already wearing off. Like, it's already starting to wear off. You may not need the full amount for reversal. So a lot of times you can get away with a half dose of reversal. And I don't like them to be like jump up and crazy. If I give half the dose and they kind of lift their head and look around, I'm like, okay, that's enough for me. If they've just been sedated, I don't need them 100% awake. Let them wake up slowly. That's my opinion. And the anesthesiologist, he did not like to, you're taking them from a completely asleep to completely awake. You have to think about, did you do anything painful? Because they're going to be much more aware of what you did, and they can come out very excited. Okay. So the note here is reduce the dose if it's been more than 30 minutes since you gave it. Like I said, though, guys, clinically, practically, I always draw up the full amount. And then if I reduce my amount, I might give half of it, and the other half I might pitch. I might just throw it away. Sometimes I draw up the reversal and I never give it because the patient woke up on their own. I'll put it back in the bottle. I mean, if I never touched an animal with that syringe, if I never touched, anything, and I drew it up just to be safe, dexdomitor is fairly expensive. If I didn't say that, that's another comparison of xylazine and dexmedetomidine. Dexmedetomidine is fairly expensive. Xylazine's dirt cheap. So if you're price comparing, your dexdomitor is more expensive, but it's still better for small animal. Now, you can reverse them in an emergency. I hate this second reason. If they want to send the animal home, to me, tell the owner to come back in a couple hours. I mean, if you've got antsy pants waiting in the lobby for a precious Fifi that can't leave them at the vet, I mean, I've had doctors reverse them just so they can go home. You can do that, I just think it's better to wake up from sedation slowly, quietly, and let them sleep it off. So you guys in surgery, sometimes Dr. Ritz will reverse them and it's been maybe an hour, but sometimes if they're really hypothermic or very sleepy after surgery, she will reverse them on recovery. So it's up to you guys. If you're the anesthetist, you'll communicate with Dr. Paul or Dr. Ritz and they'll decide if they're, oh yeah, X in the dirt, dirt cheap. That's a good one. I like that one. It'll be up to your doctor. But I'm going to tell you, IV reversal, be ready. Somebody better be holding that patient because I've seen them go bonkers when you wake them up. Yohimbine is for xylazine. Again, really ignore the ratio. It's typically equal volumes. You just have to check with your doctor. So typically whatever you gave pre-op, you're going to give for your reversal. And then antecedent is specific for dexmedetomidine. IM is the preferred reversal. IV is typically for emergencies. Yeah, so Ray, you can appreciate the fact that, you know, you've given an animal a sedative. They've been through well, they don't know what they've been through. They don't know they've had surgery or x-rays or whatever. And then when they wake up, they're like, where am I? Who are you? What are you doing? Why am I on this table? What's this cage? Da, da, da. Now, let me bring up another important point. When you give these drugs, all anesthetic drugs, if you get a bottle of acepromazine, if you get a bottle of dexmedetomidine, there's something called the bottle dose. If you look on a bottle, it, like Dexdomitor, will give you a little weight range and said if your patient's 0 to 10 pounds, this much, 20 to 30, this much. I never use the bottle dose. I never, ever, ever use the dose on the bottle. The dose on the bottle is if you're using the drug by itself with nothing else. Most of the time, Dexdomitor by itself, you're going to have to give so much more. That's why we do Dex and butorphanol together, because then I can lower the Dexdomitor and give an analgesic on top of it. So when I'm reversing these drugs, that's kind of why I usually just do like the equal volumes. But I just want you to be aware of that. And I think I forgot to mention that, is that if you look at the bottle, they are not accounting for you giving it with anything else. They're just saying, if you give this drug by itself. But again, when you use bottle dosing, those doses are much higher than if you looked in Plum or you used your clinic's protocols. Okay. So I don't typically use that dosing. I typically, usually your clinic will have some list of protocols and list of dosages, but I want you to be aware of what the bottle dose means. It's sometimes printed on the label. Sometimes it's printed on the box that the drug comes in. Ignore that. Ignore it. And the other thing with reversal, like I said, I've had dogs we've reversed and we've resedated because they woke up so bad. I've had to hold them down screaming and re-knock them out because it was not pretty. Now, when you guys are in surgery, these dogs are pretty sleepy when they wake up. You use pretty good drugs. They're cold. They've been under. But like when you guys are in radiology doing x-rays, those patients haven't been down as long. You're not using other drugs. But again, most of the time, it's going to take you guys a while to take your x-rays. If you're past 45 minutes to an hour, most of the time those dogs can just wake up sedated. I prefer to not reverse at all. I prefer to put them in a cage, let them wake up. It'll wear off. I'm not a reversal fan. That's another doctor preference. But I want you to be aware because you'll be the one holding them, doing it. Okay? Now, I want to talk about opioids. Let me get into this. That the reason we give opioids, and they're derivatives of opium, they produce analgesia. That's why this is underlined. I've tried to, in these slides, underline the primary reason you give these drugs. You will get sedation with different opioids, but if I have to sedate a dog for a nail trim, I'm not giving it morphine. It's not a predictable sedative by itself, but when you combine them, if you guys want to do radiology rotation with just butorphanol, it would not be fun. It would not be fun. They'd maybe be a little sleepy, but when you combine it with dexmedetomidine, then you get the sleepiness, sedation, and you get some analgesia, and butorphanol potentiates, they work together. So opioids or analgesia, there is a form of induction agent that I'll talk about called neuroleptal analgesia. I can combine a drug like hydromorphone, which is an opioid, and then I can give it with diazepam, not mixed in the same syringe, but I can give them, and I can induce anesthesia. Neurolept, neuro effects, analgesia effects. The way that we're going to break them down are these categories. Let me get to the next slide. It'll make more sense. So you can have agonists that are called pure agonists. You can have partial agonists. You can have agonists, antagonists, and antagonists. So when I get into the opioids, they're going to fit into a certain category. These are the ones that I'm going to talk about. So the ones that are on these slides, you can see that we have more pure agonists. Morphine, hydromorphone. Most of the time in practice, I don't think people are using oxymorphone anymore. I think most, like at VCA, we use a lot of hydromorphone. We use it a lot. And then there's fentanyl. And fentanyl and these are all Schedule II. Your agonists are your Schedule II because they have the highest abuse potential. And then your buprenorphine's a little below that as Schedule III. Our butorphanol is 4. And then naloxone, which is the reversal, is not controlled. So naloxone does not have to be locked up. But they are controlled. You can give them many routes. I mean, we can give them a morphine epidural. You can actually have, I don't think I've ever given rectal morphine. But butorphanol comes as tablets. So you can give it oral. I should say sublingual on here because oral is different than sublingual. Oral is meant to be swallowed and ingested. Sublingual or buccal, we can give buprenorphine to cats and they will just absorb it under their tongue. So the clients, we can send it home and the clients don't have to actually inject it. The nice thing is very safe. These drugs, even though when you look up these drugs, you're going to see a lot of people talk about opioids as severe respiratory depressants. It does depress respiration, but in safe dosing, they're going to be respiratory depressed anyway, but it's not going to be that. I mean, your heart rate, respiratory rate will be lower, but if you're using the pure agonist or a partial agonist, they are reversible. So the nice thing is if you get into trouble, they are reversible. That's a nice thing. I have a little chart that I'm going to take a picture of and maybe post it to your Facebook page. There are different receptors, opioid receptors in the body. Now, endogenous opioids or endogenous opioid receptors, you get endorphins and you feel like this euphoria. You feel euphoric. That's what the drugs are trying to mimic, is to treat the pain and give this feeling of euphoria. So the receptors that we focus on are mu, kappa, and there's going to be delta and sigma. Mu and kappa are the two primary opioid receptors that you're going to hear. Sometimes they'll call about these drugs and they'll call them a mu agonist or a kappa agonist. It means that it goes to that receptor and it causes that effect. Each opioid has a different effect. and I will have to, so this is what I'm going to take a picture of. I don't know if you can see that, but so I've got what happens at mu, what happens at kappa, and what happens, what's my last one? Sigma. Okay. When you agonize a mu receptor, you get euphoria, supraspinal analgesia, but you also get respiratory depression. I'm going to send this to you. Now, whenever you agonize a receptor, you get good and bad effects, okay? We want the euphoria and we want the analgesia. What we have to deal with is some respiratory depression. And, you know, kappa, you get some sedation, okay? Mu is not really a sedative receptor. So what I'm going to talk about, if I give a drug that's a pure agonist, it goes to all of these receptors and it causes effects at every receptor. If I'm a partial agonist, I only go to a few of these receptors. If I'm an agonist-antagonist, I agonize a few receptors, I antagonize a few receptors. And if I'm an antagonist, I go to all these receptors and cause the opposite effect. Does everybody understand that? So, again, pure agonists are going to go here and give me everything. Partial is going to give me some of what I want. That's why when we really want to give analgesia and some sedation to a patient, you're better off going with the pure agonist because it's going to give me the effect at everything I want. Okay. And when I go to, so we're going to get into that. So there's different actions at different receptors. So for example, sorry, my delivery's here now, so Bo is in killer mode. So an agonist, what I want you guys to know, the agonists, if you're doing painful procedures, fractures, spinal surgery, massive abdominal exploratory, it's going to be better for your moderate to severe pain. When we do partial agonists or agonist-antagonist, that's mild to moderate pain. Elective surgeries, torn toenail, we use it for some radiographs, but you know, so you've got, for example, your agonist-antagonist, they bind to mu and kappa, but they only stimulate kappa, so they don't give me the mu effects. So, I'm sorry, if you were going to operate on me, give me morphine. Don't give me some weenie little drug. I'm like, dope me up. I want good drugs. So now, we do not carry any pure agonists at the school because of record keeping and issues. We only carry buprenorphine and butorphanol. So we're not going to get into, but you know, again, we're not doing the types of procedures where we would need that. At VCA, we have them all, but we are doing major surgery at VCA. So then we would have all of those drugs. Some of the effects of opioids to be aware of, and it depends on the animal. In dogs, our opioids will give us sedation. Now, obviously, pain relief. All patients are going to get pain relief. Dogs, in some of these drugs, are going to have some sedation. It's patient dose dependent, not predictable. They put them in a narcosis, narcotics, state of sleep, if you give them with something else. Morphine by itself, unless they're debilitated, oh, Caleb, I can't even imagine not getting drugs after surgery. Oh, it's crazy. What I want you to know here is cats and horses. This is on slide 48. Ruminants to some degree. They will actually get CNS stimulation for opioids, and you can get very bizarre dysphoric patients. Dysphoria is when they're screaming out, crying, paddling. There is a theory that horses and cats have more opioid receptors. So when you give a normal dose to a horse or a cat, they're going to have a more profound effect, but we're going to get into this dysphoria. when you stimulate, I'm going to give you an example. Sigma receptors cause dysphoria and hallucination. So if I have a cat or a horse and it binds really well to sigma, you're going to see that dysphoric effects. Now, I can handle a 10-pound cat that's dysphoric. I can wrap it up in a blanket. I can stick it in a cage. If I have a 1,500-pound thoroughbred that's dysphoric, no thank you. So I'd much rather deal with a dysphoric cat than a dysphoric horse. So most people will not use pure agonists in horses. They will stick with like butorphanol or something like that. I have used pure agonists in cats. I've used hydromorphone. Mostly I've used hydromorphone in cats, maybe a little bit of morphine. When I give them morphine, I give them a big slug of acepromazine. I give them a big dose of sedative to try and override that dysphoria. I am not weaning on my ACE dose. It's not that we don't want cats to not have that effect. I want them to be relieved, but they just have a more profound. Hang on one second. Okay, I just want them to have a more profound effect. Okay, and then analgesia, you can give lower dosing. So I'll lower the opioid dose in a cat and I'll give them more sedative to try and fix that. And then analgesia is the big thing. The pure agonists are better and they're good as a pre-med. Okay, well, I know it's 11 and I got to catch my son because he's headed somewhere. So what I want to do tomorrow, I do want the homework due. I'm going to briefly go over some of the different opioids and kind of review for the test because I don't want to get too behind. So I still want to try to have a test on Wednesday. But what I'll do, yeah, go ahead, Haley. You can ask a question about the homework. Go for it. You can either unmute or type it. Maybe it'd be better just to unmute yourself.
Yeah, sorry. So for the categories of drugs on the homework, are we writing those up too?
All I want you to do is like, why do I use anticholinergics? It doesn't have to be, why do I use benzodiazepines? Why do I use phenothiazines?
So just why we use that group as a whole?
Yes. And then when you write up the individual drugs, I want you to write like, this is a phenothiazine. This is an opioid. This
Okay.
is, you see what I'm saying? But
Okay, so
I just want you to be familiar with why we use that category, like what that category of drug does, and then what are the drugs in that category. Does that make sense?
just write up why we use anticholinergics as a whole, and then each individual drug, we just put them in their groups. We don't have to put why.
Correct.
Okay, thank
Yeah,
you.
yeah, because when you write up the individual drugs, you'll put like the effects, side effects, like yeah. As long as when you put Valium, I want you to put somewhere, this is a benzodiazepine, but you've already told me somewhere in the homework, why do we give benzodiazepines?
Okay, thank you.
Yeah, for the test, what you need to be familiar with is I might say a name of a drug and I might say, what family does this drug belong to? And then I will probably ask you some key components of that drug. But I've tried to highlight, because again, diazepam and midazolam pretty much do the same thing. Or they have you give those drugs for the same reason. Then something makes midazolam different from diazepam. Cost, route given, right? Acepromazine is easy. There's only one phenothiazine. And then the alpha 2s, why would I use xylazine over dexmedetomidine? Large animal versus small animal cost. But I will try to hit some of that, and I'll try to hit some of the opioids. Okay. Are there any other questions? Okay, well, if not, we will meet tomorrow. The homework will be due. Make sure that gets turned in. And okay, Ray, that's fine. If you're done, you can go. I will get this converted. But if you have a question, shoot. You too.
Can I just ask this way?
Huh? Yeah, it's just, yeah, you can ask this way.
Okay. So I have to get my wisdom teeth taken out in about a month, and I'm not supposed to, I'm supposed to avoid NSAIDs, and one of the drugs they give you is ibuprofen. So is there like an alternative I can take, or am I just going to be screwed?
Are they going to prescribe you something? They
The
might
doctor
give you.
told,
Oh, go ahead.
he just told me that I'm just going to have to use a lot of ice, and